Good morning, everyone. Good morning, Professor Oni. I hope you're well on this beautiful, crisp Thursday morning. It's at least sunny in Cape Town. I would like to say a big welcome to Professor Oni. I don't know if it's sunny in London.
Yes, against all odds. It's not raining.
Imagine that.
Not yet.
Yeah. So I'm really excited about today's talk, and I think today's talk puts a different spin on how we think about sustainability, but more importantly, I think it includes or brings to the table something that a lot of people don't think about. So before we start the talk, I know Professor said that I shouldn't actually do it. I'm going to go through her bio a little bit and pick up some key things so that we know who it is that we're talking to. So Tulula Oni is a public health physician scientist and urban epidemiologist. There's apparently only one in the world, and you're going to listen to her today. She's also the principal at Oni et al. And founder of Urban Better. She jointly leads the Global Diet and Activity Research Group at the University of Cambridge and is an honorary associate professor in public health at the University of Cape Town, where she leads the research initiative for cities' health and equity. She has worked as a technical partner and scientific advisor for various organizations, including Future Earth, World Health Organization, World Obesity Federation, International Science Council, the African Academy of Science, and Wired UK. She's a member of the global community of experts of the African Development Institute, African Development Bank, and the UK Independent Scientific Advisory Group for Emergencies. She's an editorial board member of the Lancet Planetary Health, Cities and Health, and the Journal of Urban Health. She has been profiled in the Lancet Journal, Science Magazine, the British Medical Journal. She's a fellow of the African Academy of Sciences, is Somoloso Fellow of the Stellenbosch Institute for Advanced Study. She's the past co-chair of the Global Young Academy and the South African Young Academy of Science. She's the 2015 Next Einstein Forum Fellow. She's a 2019 World Economic Forum Young Global Leader, and she's the 2020 Next Generation Foresight Practitioner Fellow. That was a little bit long. You've been very, very, very busy, I must say. So I'll start off a little bit with one of the quotes that you always say, which is, health is everyone's business. What do you mean by that?
Right. I say that because it gets at the reality that often when we think about and we talk about health, colloquially, we inadvertently are talking about disease. When we talk about health, we think about hospitals, we think about clinics, we think about diseases that people have. Whereas in reality, that is the absence of health. And we know, for example, that the vast majority, over 3/4 of factors and exposures that influence health lie outside of the healthcare sector. So we subconsciously feel and act as though health is the responsibility of the healthcare sector. But in reality, the spaces where health is made or undermined is all around us. And I think the pandemic, it only took a few seconds before I brought that up, has really highlighted. You don't see everyone else going about their business and saying, well, we'll leave the healthcare sector to deal with a pandemic because health is not, it's got nothing to do with us. No, why? Because it has been so pervasive, and it is really highlighted the multi-dimensional and cross-sectoral determinants that drive health. And so, yes, health is everyone's business.
That's an interesting way of putting it. I'm going to go back into the fact that you're the only urban epidemiologist in the world. And I'm going to maybe briefly ask, how do you move from kind of being a physician and kind of move over into an urban practitioner? So for me, that combination is an interesting one. I actually haven't heard of anybody who calls themselves that. So what was your journey to get there?
Yeah. So before I do, I can give everyone a little hack. So if you want to be the first person or something, then you just basically invent the term, And then because nobody else is using it, you become the first and only. More seriously, so I, like anyone training to be a doctor, I thought that what I wanted to do was to treat people, right? But underlying all of that is the drive to improve the state of things. So why want to treat people if it isn't about improving well-being, right? And improving population well-being. Somewhere along that line, actually during medical school, started to get exposed to the issues that were bigger than our core training. So the core training obviously takes you through the body and different aspects of the body. You learn how things go wrong, what needs to be fixed. But I started getting exposed to drivers of health beyond borders. So understanding that, yes, actually what you see at the clinic or at the hospital is a manifestation of something gone wrong in the body. But long before that happened, the exposures that are either in the immediate environment or even beyond their borders have set out that cascade that led to them walking through your door. So it got me thinking about research initially, because I thought, well, how do you get behind disease rather than waiting for diseases and treating them? How do you understand the drivers? So when I moved to South Africa, it was 2007, I went for 12 months because I wanted to just get a sense of, because I was working in HIV in London previously as a clinician, and I wanted to get a sense of the research, right? So I did PhD in kind of HIV, TB, and understanding that epidemiology. So that was the basic epidemiology training. But within a few years, started realizing that at some point, I'd moved from wanting to treat people to treating diseases. And that sounds pedantic, but the reality was that we just sat in the clinic and waited for the diseases to present. I started realizing that the TB, HIV patients I was seeing, when you ask a little bit more, you realize that, oh, okay, they also have other conditions. They're battling with diabetes that's poorly controlled, blood pressure that is too high, obesity. And all I did was say, well, you've got to cut down your salt. Well, you need to exercise more. And then they would smile and nod and say, yes, doctor, that's important. And then I'd pat myself on the back because I did a great job as a doctor that day. And I did even more than TB that day, don't you know? I started realizing when you walk outside the clinic, I started asking, well, how rational is it to expect people to essentially undertake irrational behavior? So if you are needing to be physically active and to walk more, but walking more is detrimental to your safety in terms of injury, in terms of violence, is it actually a rational behavior to walk? It's not, right? So I realized I was asking people to be irrational. So I thought, well, how can we actually make that advice rational? And I realized that I couldn't do that from the clinic or from the hospital, because that was beyond the reach of the healthcare sector. So that was the beginning of reaching out beyond that to say, well, how do we understand the environmental exposures that people have, both from their homes to the immediate environment, to their broader communities, to the intersection between home and work or home and school, all those different exposures, be that in the natural environment, the built environment, the social environment. How do we understand how they navigate those? How do we understand how they influence health? And importantly, how can we intervene in those spaces to create health? So urban epidemiology is a kind of bastardization, if you like, of epidemiology, which looks at the disease, to look at the urban, to say we can't look at disease, but without looking at the root causes.
So, I mean, like, as you talk about it, it was starting to make sense. When you look at health, we all think, I'll go to the doctor when I have a flu. I don't think that my immediate environment can be the one thing that changes that. So you talk about diseases presenting as opposed to looking at the choices and the behaviors or the limitations of those choices within our environments. So I'm going to extend you a little bit on the idea of behavioral choices. And I think within the built environment, as spatial practitioners, architects, quantity surveyors, engineers, the idea that the things that we do or the designs that we come up with actually limit or impact on people's behavioral choices. So maybe if you could just extend a little bit of that. So if we take what started as your core research, which was HIV and TB, how did the research that you uncovered give you insights into how the urban and the built environment actually starts to negatively and sometimes positively impact on behavioral choices?
Well, maybe just to do that in reverse. Often when we talk about diseases like the emerging epidemics like obesity, like hypertension, certain words come to mind. So choice, behavior, lifestyle, which is one of my top worst words, and I'll tell you why in a moment. We tend to focus on the act of the individual, which makes sense, right? Because there is a you have to do something with that exposure in order for it to have to impact on your physical and mental well-being. A lot less do we focus on, well, what is a definition of choice? Choice implies options, right? Lifestyle implies true choice. And I don't mean something hypothetical availability. So for it to be lifestyle, it implies that I have access to all of these healthy, unhealthy choices, and I am choosing the unhealthy, right? And when I say access, we have to think about all the different dimensions of access. So there's the geographic accessibility. So how proximal, how close is it to you? There is the availability. So how often can you actually access it when it's there? There is accommodation. Does it work with your timeline? So is it sufficient to have healthy foods next to you if they're sold between 9 and 4 and you commute 2 hours to work, and when you leave home or when you come back there is no access to anything, but you know what's open 24 hours? The choices, so can we think about all those different dimensions of access? And only when those are all ticked and equitably accessible can we actually start talking about choice or lifestyle. And so what got me, so if we think about TB, for example, one of the things that pushed me to looking at the non-communicable diseases, so things like diabetes, and we realized that, and we've known this for 100 years, diabetes increases the risk of tuberculosis by up to 3-fold. This has been known for over 100 years. But it's not been a part of how we treat people, because previously they were different populations, right? So you got TB, and then if you survived, and then you got richer, then you got obesity, and then you got diabetes. So they were in different populations. So it was always a kind of hypothetical interaction. Whereas what we're seeing at the moment is the inverse. So they're not diseases of affluence. We see, and this is not just in South Africa, in the UK, colleagues of mine have mapped out food environments across the country, and the clusters of high density unhealthy environment are in the poorer and more deprived communities. So that's what you have easy access to. That's what becomes the rational choices. The advertising, the marketing is very much targeted at those poor and debt-deprived communities. So I realized just from a TB perspective, in South Africa, we know HIV and TB are very closely connected. And HIV is the strongest risk factor for TB, for example. But we're less known that actually to improve TB outcomes, we also need to prevent diabetes, not just pick it up and treat it, but can we actually prevent it? And what a missed opportunity, where we see people day in, day out, and all we're doing is waiting for them to pick up yet another disease. So we see them, we send them back out to the same conditions that we know eventually you'll come back with a second disease that I'll have to send you somewhere. I mean, it just makes no sense. And not only does it make any sense, period, it doesn't make any financial sense either. So the cost of treating is just exponentially more than the cost of prevention. But the challenge is the timelines. And that's what the two challenges, the timelines and the governance and accountability. So in terms of timelines, we as human beings, I think we struggle to act with sense of urgency when things are not right here and there in front of us. So would we have, with COVID, if exposure to SARS-CoV-2 meant that next year, a year or two after exposure, we'd have this mortality and this amount of spread, but it took a while, would we have acted with as much urgency? With the same outcomes, with the same impact on mortality and on morbidity and on poor disability and well-being, would we have acted with the same urgency? Unlikely. And I would go beyond unlikely and say definitely not, because we see that with the climate emergency. So we're less able to act, or we're less likely to act with sense of urgency when emergencies are protracted. And that is my frustration. And then the second thing is the accountability. So, which is related to the first, because the healthcare sector are held accountable for health of populations. The sectors where health is being created or undermined are not accountable for health. The health that they create or undermine doesn't happen immediately. It takes time to unfold. So things are happening in our environments, and the people driving and responsible for building those environments it's not in their KPI, it's not in their mandate to think about the health that they're trying to create, or the health inequity they're trying to address. That's not within their remit. And then the impact, the follow-on, knock-on impact of what they do on health years later also doesn't come back to them either. So you have this complete siloed accountability for health.
All right, thanks, Prof. Oni. I think that speaks to Eben's question, where he was saying, how do we begin to address with design this inequality within urban areas in order to address disease? And based on what you're saying is that, and also if I look at the awards that this webinar is being run through, which is the Sustainability Awards, and you look at what we're looking for, the timelines aren't quite as long as the timelines in terms of the impact when it comes to disease and when it comes to health. Mm-hmm. So, I mean, we can't get away from COVID. So I'm going to put COVID on the table. So if we look at if we look at the immediacy of COVID, and I think it's the rate of infection, it's the mortality, it's what it can do to you. Pretty much you can pick it up if you walk out of your house. The immediacy of COVID we're probably, from what you're saying, from a health perspective, we're going to see the repercussions of that in 5 years' time. whereas the built environment is trying very quickly to address that immediacy, but we're actually losing out on the long-term effects. So if you were to fold health in as one of the criteria for sustainable design, how would you fold that into a brief, into an award, into a way of being, into a practice?
So the one thing that comes to mind is data and awareness of health need. So if somebody working in sustainable design said to me that they were designing to improve the well-being of a particular user of the areas or community or whatever, I would ask you, what are the top 5 health deficiencies in that population? What are the top 5 determinants of those deficiencies? In what ways, how are the different components, how do the different components of what you're designing interact with those determinants? If you don't know the answer to that, I will quote you what I say in those circumstances, which is that health does not trickle down from good intentions. And that sounds like something that is obvious, but we inadvertently assume that as long as I use good standards and as long as I mean well and I tick a couple of boxes, it will be good and health will just follow. It's not true. I'm sorry. It's not true. The best case scenario is minimizing harm. So the second question I would then ask is, to what end do you wish to impact well-being, health and well-being? Because if all you want to do is not be the bad person, if all you want to do is not be the polluter, sure, don't use lead and then don't use, just there's things to just not be the really Dr. Evil. But is that all you want to do? And is that enough to give you, should we be giving anyone a pat on the back for not destroying? I'm not sure we should. If you proactively, sorry, I'm being provocative. I could be more provocative, but I'm controlling it. If you actually look around you and you see deficits in health, and you want to sustainably look at how you can address that, that takes a lot more conscious and deliberate action, and that will take you outside of your comfort zone, because you need to understand what are the health needs, how do you understand it, and importantly, and this is maybe important to stress because people can't do everything. It's the importance of partnership, and the importance of research. And I'm an academic, so one half of me is. But I truly believe there is a lot that we don't know. There's a lot that we know about how exposures impact on health, but there's a lot we don't know in terms of the best ways of doing that. And so the two things that would need to happen is, I would say, well, who have you partnered with? Who knows more about this than you do? Because you can't just set aside all your training qualifications, like I'm going to go training in public health. Like no one's expecting to do that. But there are plenty of people out there that would be open to partnership to inform that, and then to measure. The measuring is and that's the not trickling down from good intentions bit, because you can do all of that. You can partner, with somebody who knows the literature and understanding and advises on how best to do this, to add health and sustainability into the design of whatever it is that's the initiative. but we need to measure it. So how do we, what are the key things that we want to influence? So do we want to influence the way that people socialize? Do we want to measure the way that people move? Do we want to measure the way that people eat, or what people breathe, or mental health? Or what is it that you want, that you think this can influence? Measure it before, if they're not data, or I mean, I partner with people. This is what people like me do. Roll out the intervention and your initiative and measure it afterwards over time, because it is a complex system. Because even with good intention and even with deliberate action, there might be things that are there might be oversight, and there might be unintended consequences that may be a lot worse than the potentially positive consequences. And the last point I think that would be important, so partnership, research, and engagement. Quite a number of the unintended consequences tend to be, so in my experience of things that I've done that have had unintended consequences, have been things that I thought were unintended and unforeseen. But then I speak to somebody else who has more on the ground experience and said, well, I could have told you that would have happened. But I didn't think, I just assumed, because it wasn't even a question, right? So I just, obviously the questions I had, I engaged, but there's certain things that we just make assumptions about what people want, how people prioritize, all of that. And so meaningful engagement with the people that you're trying to influence is a critical part of doing anything impactful.
Wow, that's really breaking down. I think I'm looking in the chat and people are kind of, this is bending what we think about buildings or sustainability in buildings. But I think to ground what you've just said, so it's the three key things, which is engagement, which is about the research, and which is about basically the data. Understanding the data of the demographic that you are working in, doing the research and engagement. Could you give like a real life example, say in Cape Town when you were here? So in terms of one built intervention as opposed to what was existing, and how you could do that.
So I can give an ongoing example. So we have got a project in partnership with the Western Cape Department of Human Settlements, which has been along for a number of years. And it started off not for anything specific, but just because we got people together, because that's the first part of breaking the silence, just getting people together. So got people together about 5 years ago, just to say, let's hear what your priorities are across these different sectors. So we had all these different sectors represented, and let's hear, what you think about. Let's look for opportunities to integrate health into those spaces, because you're invited because you might not think you work in health, but trust me, you do. And the person at the time then said, we know what we do matters for health, but it's just not. It's not it's not what drives, it's not the incentive, it's not what the indicators of our performance are. And so understandably, we are driven by the mandate and what you need to do, but we'd like to do it differently. So it's like, okay, that's all we need. So we worked together, and we actually wrote a project to do together, and we got some funding to do together, which is to look at in the context of informal settlement upgrading, because that's there was a shift in the department to focus on doing that, to improve the environment and build the built environment exposures for people in informal settlements. So I thought, that's a good opportunity, because we know those spaces impact on health, but just because you do something does not mean health does not trickle down from good intentions. So in what ways can we partner to better understand the potential for your intervention to improve health? So first thing we realized is that the data on the health of those communities and on the built environment were lived in completely different places, right? So if we ask the human settlements, what are the key things? I mean, you could guess, but informal settlements are heterogeneous, right? So you say, well, what are the hotspots of where under 5 diarrhea is? You don't know, and why would you know? It's a completely different department. So the first thing we're doing is bringing those data together to say, can we, by doing that, help firstly understand what the key priority intervention should be, because the upgrading of informal settlements is there's a suite of potential options. But by understanding what the priority health needs are, can that inform the order of things that are implemented firstly, and can it inform where that is done first? Because obviously they're not going to roll everything out at the same time everywhere. But so can the health need inform what is rolled out and where it's rolled out? So we're doing that at the moment, and then the idea is to then have that roll out, and then we'd be in a position to look at, well, what impact did it have? And to continuously improve that. Another example, not from my work, but from others, of health not trickling down from good intentions was, and I'm sure this has been a fix now, but years ago with LDP houses, so that, the common knowledge is that shacks and informal settlements bad for your health, solid formal brick houses good. So we will just focus on building the houses. I mean, and who can challenge that, right? Build the houses, health will improve. And then someone did some research and found that in South Africa, the ventilation and the air changes per minute in some of those RDP houses were worse than in the shacks. So then, do you see what I'm going at?
Yeah.
If you don't ask the question, what are you trying to do? Or what are the key issues? Because if you were to ask, well, what are the key issues in this community? You wouldn't have need any research to tell you TB was way up there. And then you ask yourself, well, what are the ways in which what we're doing could impact on transmission of TB? And what are the ways that we could reduce that risk measurably? And then did we do that? So those are just a couple of examples of what is possible on both ends.
Wow, that's quite so what I'm finding extremely uncomfortable about what you're saying.
Oh, good. I've succeeded. If you're uncomfortable, that was the entire intention.
I'm finding certain things relatively uncomfortable, but that discomfort, I think, is giving me a bit of hope, and I think, particularly because of the COVID scenario, these are issues, and I think that's one of the things. I was trying not to talk about COVID, but I think one of the things COVID has done is that it's shown that it's an inflection point where we realize that it's a cross-cutting issue. Whereas before we had health, we had built environment, we now realize that actually it's one thing that cuts across different sections. But I'm going to take a COVID question. So Anele asks, Dr. Tula, do you think COVID has done a great job to foreground the importance of health-enabling urban spaces and architecture?
Yes. Next question. No. I mean, foregrounding is an easy answer, right? Is yes. What is more challenging is the so what. What does the foregrounding achieve? Because again, foregrounding it does not necessarily equate, oh, now that we know, everything will change. Because there's give and take. There's a tension, and there are difficult decisions to be made. So if it's foregrounding, that's great. If it's making us uncomfortable, that's good. If we have the courage to confront that discomfort, and to say, well, what are the ways that we can do things differently? That's even better. And I mean, we see that as an example. If you look at COVID just from a perspective of all the different dimensions of the built environment, from the house a lot of transmission was going on within households, right? In the UK, it's foregrounded the fact that very little of the house building reflects the changing dynamic of different communities in terms of multi-generational living and those actual needs. So you build houses just because there's a cookie cutter, this is how you build houses, a completely disconnect with what people need. People will use them how they use them. And you end up with a situation where the house, the built structure is not, it increases the risk of transmission, firstly, reduces your ability to shield or to self-isolate too. If you step outside of the household, the kinds of environments that people live in, houses don't exist in a vacuum, right? They exist in spaces and places that are created. If they're created from a perspective of how do we put more houses in and make them all sustainable, and that's great, but let's just chuck them in, then we've come to the point where we realize that, suddenly when the safest way to go for a walk is to be outdoors, well, how have we built the outdoors? and who has access to those kind of spaces that allow you to be able to do that safely? Even beyond that, if you go into the medium term, and we've got this 4 of the mind here, we know that there was a paper that was released by the World Bank yesterday, or commissioned by the World Bank, that showed that obesity increases the risk of death from COVID by almost 50%. So here, the Prime Minister of the UK has been like, okay, we're on a war against obesity. Finally, we do this as a way to reduce it's like, that's all well and good. But can we take a systems approach to doing that? Because at the same time as that is happening, and we're addressing marketing and advertising, and that's great. At the same time as that, there is a drive for the economy, and we're going to build, quote unquote. I'm getting a little bit political here because health is political. We're going to build, and that's important to drive the economy, construction, etc. But in order to do that, evoked permitted development rights that bypass the need for the kinds of consultations on the needs that address the needs of the community, that bypass the need to contribute to affordable housing, that bypass the need to contribute to the common public shared spaces, the playgrounds, etc. But it's good because we're building, and then there's not dissonance. There's dissonance, right? There's not a connection. So foregrounding, good. But we have to recognize the complexity, and we can't shy away from the complexity. We have to understand, well, if what we're trying to do is reduce the risk of severe disease, and we want to do that through addressing X, then let's look at how all the different decisions we make point in the same direction.
I'm going to comment, I think, something from Martin, and he says basically what you're talking about is a kind of logical framework approach that
I'm glad it's logical.
Planning with measurable outcomes. I think Martin got that one.
Right.
Martin's definitely away. I'm going to ask a question from Andrew, and Andrew wants to know what you think about the proposed relocation of residents from high-density areas such as Alex as a response to the prevention of COVID, or let's put it broadly, like extremely infectious diseases.
Mm-hmm. It always boils down, when you're addressing a systems issue, I always start by asking, I don't know the details of the Alex situation, so I'm going to speak from first principles. What are we trying to achieve? What is the problem that we're trying to address?
Mm-hmm.
You start there. And who defines that problem? So is it me driving past it every day that sees it as a problem, but when you ask people in there, they have 3 other problems that they think need addressing? So there's a power dynamic that is important to address. So when you're in defining the problem, and I say that because physical, social, mental health can't be divorced, right? If you don't understand how people with chronic diseases say have the care that they get, the care that they need, not just from the formal services, but from around them. An example for a COVID example, for example, was obviously we had the lockdown restrictions that, the very blunt public health instrument, but it was all we had in our toolbox to address an emergency. Not in South Africa, but I can't remember which country now, found that by doing that and not taking into consideration how people stay food secure, they realized that the food insecurity went up significantly because people borrowed from each other, right? So I come get this from you, and in a way that is so informal that wasn't even on the radar. So suddenly you lock people in their homes and they can't eat. It sounds really obvious, right? But you have to be thinking about the problem for it to be obvious. So that's a tangential point. And so to the point around what you said around Alex, like, well, it can, very simplistically, you say, well, these areas are crowded. Overcrowding increases risk of transmission. Let's disperse people. I'm afraid that's far too simplistic, and I'm sure that's not what's happening, and I'm sure they're engaging with the complexity of the different components of the system that would be influenced. But we see that happen time and time again, where it's easier to do one thing. It's like there's a whole bunch of these things and you feel, paralyzed by the scale of it. So what I can do is make it look less crowded. But that's akin to the RDP house example I was giving.
Yeah.
Right? So I think what is coming, the point I'm trying to get at is that in addition to taking health into consideration as to front and centering it, I think built people that work related to built environment have to increasingly be skilled to address complexity, and to take a systems approach to things, because it's not just about finding what you have the remit to change and then just going about it, because you're not connected to the follow-on consequences, and it doesn't come back to you. So it really is, I think, as long as it's taking a systems approach to understanding on the follow-on impact. I mean, we see this, for example, before COVID, in previous pandemics, Ebola. We see these unintended consequences within the healthcare system. We see a displacement. So when you have an acute problem, everyone goes to address this. You have a whole host of resources diverted to address the matter at hand. But more people died from malaria, as excess deaths from malaria, than from Ebola in the areas where we're that pandemic. I mean, over and above what those malaria levels, because there was not people didn't seek healthcare for it. We see that time and time again. So you have a displacement of a problem, and that shouldn't be conflated as solving the problem.
All right, thanks a lot, Prof. I think we're coming to the end of this session. I think people are quite stumped with what you're talking about. I don't think it's very often that someone comes in, except for Martin, he got it up front. It's a logical framework. You need to ask the right questions, do the research, and collect the data. But I think I don't know if there's anything, I mean, I'm also going to take a lot back. If I look at, I'm in education, if I look at the way that I teach my students, I have never, ever, ever put the question of health on the table. And I think that's a fundamental that's a gap that I need to start seriously thinking about. And the more you talk, it's actually really simple. It's common sense. The fact that I've never applied it boggles my mind, but there we have it. But if there's any last...
Simple complexity. That's
simple complexity. And you've given us a framework. Is there any last questions from anybody? I don't see any questions. I think people are trying to take it all in. Some of the questions you already spoke to. A lot of people are asking for a recording of this. Any last thoughts, Professor Oni? I just
going to re-traumatize yourself with it over and over again.
I'm going to take that framework. Before you give any last thoughts as we leave, I just want to encourage everybody to have a look at some of the work that Professor Oni has done. She's given several talks. I think recently you gave a talk to a group of architects, and that was quite interactive. And was it Amsterdam? Just before your award.
No, it was in London. It was at
London.
Yeah.
So Professor Oni has been engaging with practitioners. So just very briefly, 5 seconds, 3 things that you want everybody to take away from this before we end.
Okay, one is that something I haven't explicitly mentioned, which I think in the context of a sustainable design framework that we're speaking, I should say, which is planetary health, right? So it's just upfront highlighting that, because I think anyone listening now should go away at least having heard that term, which is that connection between human health and the ecosystems and environments we depend on, the ways that they influence our health, the ways that our activities influence that balance in that loop. So because it wasn't complex enough, I think the importance of considering that dynamic relationship between the human and ecological as well as the built is critical. So planetary health is one. Second is timelines. Think long term, think and do long term, because a lot of the significant implications of work in the built environment don't happen overnight. So think back on a project you did 10 years ago and wonder how health and well-being is going in that project right now. And if you don't know, then that's exactly the point. And the third and the third point is I hope you come away embodying, to some extent, internalizing the fact that to a large extent you're a health professional, because what you're a professional and what you do, a practitioner, and what you do impacts health much more than the person sitting in the clinic waiting for diseases to occur. So remember that in your day-to-day.
Wow, thank you very much. With those 3 things, I'm going to thank everybody for coming for this webinar. A big thank you to the organizers, which is the AfriSum Sustainability Awards. We received a lot of entries this year, and we're looking forward to how that's going to carry through. And then maybe next year you could come and help us write that brief and fold health into the Sustainable Awards. Would really, really appreciate that. Thank you to SIRE and the SIRE members who've attended this session. This session will be broadcast on several social media platforms. There's also a recording that will go up. A lot of people are asked about the recording, so I'm sure that we'll be able to engage with that again. And ladies and gentlemen, fellow health practitioners, a big thank you to Professor Oni for bringing health into the built environment. I'm feeling quite uncomfortable, but I think it's positive. I mean, I need to start thinking of myself as not just an architect, but as a health practitioner. I think that's what's going to change the way that we think. Thank you very much, and we'll catch up the next time you're in Cape Town.
Thank you. Thanks, everyone.
Thank you. Bye.